Welcome back. We are moving into altered mental status and neurology issues related to the central nervous system that are seen in pediatric patients. Major problems like stroke that are found in adults are much less common in pediatric patients. So what affects children's brains? You already learned about assessing the appearance and mental status of a child last week, but we will briefly review a couple of key points here. Mental status in a child is sometimes difficult to truly assess, and we have made it more complex by having multiple aspects of the patient assessment evaluated. The assessment of the child, especially the young child's mental status, falls into a couple of categories we teach. It certainly is part of the initial assessment triangle under appearance. You will also find it hidden in the assessment of D, which is disability, of a child as part of the ABCDEs for trauma. Can they follow directions or move extremities? Finally, we talk about AVPU and GCS, but to make matters worse, we want you to use a modified pediatric GCS since young children wouldn't get any points on the adult verbal portion of it. So if you're having a hard time figuring out how to assess or describe a pediatric patient's mental status, that's okay. The pediatric assessment triangle should be the mainstay of your initial patient assessment. A, relating to the appearance, has a lot to do with the mental status. A child that does not respond to you or interact with you, even if they are very young, would be unusual. They should at a minimum look at you, follow you as you move around them. Other signs of altered mental status would be decreased tone. Pediatric patients, even newborns, should not be flaccid and flat. Under normal circumstances, they should have some amount of muscle tone. A floppy baby, even if they respond to you or parents, is showing signs of being altered. Certainly, being unresponsive to any stimuli is also abnormal. Remember, normal mental status is dependent on your alertness and your awareness of what is going on. The pediatric assessment triangle will clue you in a little to both of these pieces. AVPU or GCS mostly quantifies the alertness. Certainly, an abnormal level of alertness means the patient is altered. However, they could be alert, but you need to appreciate other subtle findings to key into the fact the child is not aware and therefore still altered. From the initial impression of your pediatric assessment triangle and what you observe in the child, you can further evaluate using tools like AVPU. If the child isn't initially alert on assessment, are they arousable to voice, to painful stimuli in the form of a pinch of the toes or the skin? Or are they completely unresponsive? Any evaluation other than alert is a mark of altered mental status in the child. You have a required reading about the pediatric GCS to help you learn about that. As you've already learned, many things can lead to altered mental status in a child, and it should be a very concerning finding. It can be caused by anything from hypoxia to shock to trauma to ingestion or infection or a primary neurologic issue. Many of these things cannot definitively be diagnosed in the field, but you can suspect them based on your history and exam. And you should look for reversible causes of altered mentation. Administer oxygen if there seems to be respiratory distress on exam or you have a pulse oximetry reading that is abnormal. Initiate positive pressure ventilation if breathing is inadequate. If the heart rate is less than 60, start compressions. For all of these situations, initiate transport quickly. One additional critical cause of altered mental status to consider in all pediatric patients is hypoglycemia. If it is in your scope of practice where you work, check a glucose on a pediatric patient who is altered. Refer back to the course Medical Emergencies, Airway, Breathing, and Circulation to find the video on altered mental status and hypoglycemia in week 4 to further review this. Also, administration of oral glucose might be in those protocols. If you find a patient with hypoglycemia who is altered and can safely swallow glucose, consider that intervention early. Let's transition into primary problems of the brain. The primary problem you will run across in pediatrics is seizures. Seizures can be frightening to parents and bystanders and frequently result in a call for medical evaluation. For the purposes of pediatric patients, we will consider seizures in 3 types. Febrile seizures, or seizures that happen in the setting of a fever, seizure disorders, or epilepsy, and seizures caused by something concerning, like a mass, trauma, or an infection. Febrile seizures are actually relatively common. About 2 to 5% of the population experience at least one. Additionally, if a child has one, they're 40% more likely to have a second one at some point. Febrile seizures usually look like generalized tonic-clonic seizures that you learned about before. The child will not be responsive during the event and usually is confused afterwards. Febrile seizures occur in pediatric patients aged approximately 6 months to 5 years old. The hallmark features of a febrile seizure are a seizure lasting less than 15 minutes, the patient clears to a normal mental status after their postictal period. It occurs in the setting of a fever, usually greater than 101 degrees Fahrenheit. If the child lacks any of these reassuring features, then there should be increased concern for another underlying cause for the seizure. Having a febrile seizure as a child does not necessarily mean the child will go on to develop a seizure disorder. It's important to remember that all seizures that happen in the setting of infection are not necessarily just febrile seizures. Children with seizure disorder can have a fever and have one of their regular seizures. And children with meningitis can have a fever, and their cause of seizure can be the infection that's around their brain. For a more thorough review of the differences in types of seizure and primary seizure disorder in comparison to other causes of seizure, you can review Medical Emergencies, Airway, Breathing, and Circulation, week number 4. When thinking about the management of the child with a seizure, the same principles apply. If the child is still seizing, make sure they are in a safe location where they will not fall off anything or hit anything. Maintain an open airway as best you can, recognizing that frequently during a seizure, the patient's jaw and neck are very tight and things like chin lift are difficult to do. If the seizure is prolonged, consider providing positive pressure ventilation at a rate of 12 to 20 if breathing is inadequate, or oxygen either through a mask or as blow-by if it is adequate. Suction any secretions that are present, but do not place anything in the mouth of an actively seizing patient. For a seizure that is ongoing, call for advanced life support and continue to monitor the patient. For the patient that seizes, if it is in your scope of practice, consider checking a glucose. If the seizure has stopped by the time of your arrival, or you are present when it stops, your steps will be similar. First, address the airway and make sure the patient is positioned for adequate ventilation. This can be done through positioning of the airway or by providing supplemental oxygen while the patient continues to wake up. You should see progressive improvement in the mental status of the child as you care for them. Patients that continue to seize should be emergently transported. If the seizure has stopped, you can continue routine transport, of course, remaining alert for recurrent seizures. Do not forget to get your sample history and ask your OPQRST questions. This information will usually come from parents. When taking your sample history, make sure you know about the seizure history and if the child is on an anti-seizure medication, that you know if they've been taking them or not. Remember your resources to look up what different medications are for. In addition to the information gathered by the OPQRST, make sure you ask specifically about recent trauma and recent infection or fevers. Last but not least, don't skimp on your exam. Make sure you do a full evaluation of the child, not only looking for evidence of injury or problem due to the seizure, but also for any abnormalities that might suggest different causes of seizure. Do your full secondary assessment after completing your ABCs. Pay attention to evidence of things that might not have been caught initially, such as evidence of trauma or rashes. With that, we will take a brain break. You are close to the end of your pediatric sections. Make sure you are taking time to study and review these topics and principles of patient management. There is a lot here to learn.